All right. Good afternoon, ladies and gentlemen. Thank you for joining us. It's going to be a pretty brief conversation. But just to introduce myself, I'm Mirza Beg. I'm the Chief Tech Officer at LiveMed Health. We are a full-service tech-enabled virtual healthcare company with a core focus on inpatient care. Today we'll be talking about, let me read this, revolutionizing healthcare by prioritizing acuity for better outcomes. And so we are going to share with you first of all, the problem, the challenge, and the challenge is probably experienced across the board by many people here. But in addition to that, we're going to share how we approach the problem, walk you through our solution, and then also share some of the successes and the positive outcomes that we've experienced as part of that approach. So today, I'm joined by our CEO and co-founder, Dr. Samer Siddiqui, who is a board-certified internal physician. And he has committed his career to delivering innovative healthcare to his patients. And he is also a closet tech enthusiast. And it is under that motivation that has led him to create LiveMed and really pursue this path as a way to establish more accessibility for all patients across not only metro, urban, suburban, but also rural America. So in that spirit, let's get started. One thing I will say, I'd be remiss by not introducing our Director of Product Management, Sohail Hassan, in the audience, and Ali Albers, who's our Director of our Nurse Practitioner Program. And they're here comprising our presence here at the conference. And so feel free to reach us all the way at the booth right next to here. We're only barely a stone's throw away. So shall we get started?
Sure. Hello, texting. Okay, got it. All right.
Yeah. Awesome. Right, awesome. Go. So let's start out by level setting for the audience. What LiveMed Health is and the story of LiveMed, how we got started. Go ahead, Dr. Siddiqui.
Good afternoon, everyone. Thank you so much for everyone who is attending. So LiveMed Telehealth basically was born out of the need to provide specialist care to rural communities, small community hospitals, as well as some urban community hospitals, where we thought that there was a huge gap in the market when it comes to specialists. A lot of specialty care is not delivered in these places. And then unfortunately, these smaller community hospitals don't have the resources to afford the technology as well. So when we basically decided to go build about this solution, we wanted to make sure that we were covering an end-to-end solution. When we went and shopped around for telemedicine solutions in the market, unfortunately, they were too expensive to give to these hospitals. So that's when we went ahead and made our own customized telemedicine solution platform that was extremely cost-effective, but still pretty high quality. And then what we did was we attached our physician group to that digital network. And so we go to these small community hospitals, acute cares, outpatient clinics, and we give them our whole, basically, we have about 7 to 8 different specialties, over 55 different specialists, and we provide them with the tech as well as physicians, basically.
Fantastic. So let's, I know we've got a comprehensive backing and a lot of great mentors and a lot of resources for consultation, industry luminaries. You want to talk about a little bit of that?
So we had, I would say, an exponential growth in the last couple of years, and I don't think we could be here if it wasn't for our team. Myself, I'm an internal medicine physician for over a decade now. I did computer science in undergrad, but my parents kind of pushed me towards becoming a physician, so I did that too. I like that as well. We have Jonathan Goldberg. He is here somewhere, but he's our CIO. He's been CIO at large health systems, so he knows. He's been on the other side for every startup in this, in this area. You're pitching to health systems. He's been on the other side taking those pitches, so we decided to bring him on board. Mirza Beg, he's our technology genius. He's the one who's behind all the tech.
Genius is a relative term, by the way.
We have Lauren Hill. She's our chief marketing officer. We have Dr. Al-Kabiri. He is a hospital-based physician out of Chicago. He's our chief medical officer. Ali, we did introduce recently. But who I call the Michael Jordan of telemedicine is Mr. Ali Acorn. He is our chief innovations officer. He built Teledocs technology. He was the CTO of InTouch, which got bought out by Teladoc. He came on board with us last year, and it's been great having him on. And then we also have, we wanted to make sure that when we're providing telemedicine services, we want to be able to get reimbursed. We have a telemedicine director who is Dr. Paul Bannock. He's a pulmonologist by trade, but he's been with United Healthcare, so he's been kind of guiding us on our reimbursement patterns, our pricing models, and it's just been good. And then with all of this, we also need a very, very heavy legal backing, and so we are with Nestlin Mullins, and Andrew is our chief legal officer. Talking about exponential growth, we started in 2022, September, and we had our first hospital go live about 6-7 months after that. And then Q3 of 2023 was our big year where we signed a large contract over 50 rural hospitals for 5 years. Then we also got featured as one of the leading digital health companies out of Chicago in 2024. And then we recently, last month, just signed another large deal with over 50 hospitals. So there is a need, and we're trying to address it, and it looks like people are finding us at the right time now.
And we are a Matter company, so Matter is a pavilion adjacent to us, and we were born out of Matter. And so we owe a lot of our evolution and a lot of our mentorship to that program. Fantastic program. If you haven't checked out those other solutions, by the way, worthwhile. A lot of smart people and a lot of good thinking behind those efforts.
So primarily when we looked at these small rural hospitals, the issues that we tried to encounter was, first of all, they have physician shortages, they have specialty shortages. A lot of these patients can't even be seen in that hospital. They have to get transferred to larger hospitals, and that hospitals lose a lot of money in that way. And so what we decided was we tried to focus on two aspects which we could control, which was the technology part and providing them with a physician group, basically. And so you can go next. This is our whole model. Basically, we have our own physician group. We have our own secure chat platform that Mirza is going to talk about. It's an AI leveraged chat platform. When our physicians are covering several different hospitals at a time, we couldn't have these hospitals page them directly, individually. We wanted to consolidate that communication so that we're not missing anything. And so we created a product that uses AI to leverage the acuity. And then we built a device which was extremely cost effective. It's a digital health device that allows for virtual consultations. And then we provide it at all these small rural hospitals. Kind of, it comes with the package. If you get the physician services, you get the technology product with it, basically.
Fantastic. So that background will help contextualize today's topic, this afternoon's topic of revolutionizing healthcare by prioritizing acuity for better outcomes. And the reason why we want to contextualize it, because it's critical for all of us to understand how Live Med works, what our overall workflow is. We have many workflows. There's a number of workflows which we've optimized. There's many workflows that we've surfaced, a lot of challenges. These challenges are shared across the entire industry. It's not exclusive to us, but just to kind of shed light to a specific workflow, if we were to simplify from left to right what our daily, what our day looks like, essentially, we take virtual healthcare in the context of 3 simple steps. First of all, our hospital staff, our nurses, essentially reach out to a virtual doctor, right? That doctor sits on our side of the fence. They can sit anywhere remotely, and so we bring those specialists, and each of those specialists is represented by a line of doctors that obviously specialize in that field. And then that page goes out to the doctor, where that doctor will then conduct a consultation. So this is a very simple process to follow in the sequence of events. And lastly, that doctor feedback, the doctor will follow up, create that feedback, push the notes into whatever EMR specific designated system there is, and then ultimately schedules the follow-ups. That all sounds simple, but it is entirely broken. And I'm not the only person in this hall to tell you that. There are hundreds of companies in this hall to tell you that very same thing across different aspects of that workflow. And there are hundreds of companies that are collectively trying to solve all of these challenges, and obviously directly within the pavilion, the health hub that we're sitting in. Talk to all these guys. They bring a number of amazing solutions, and so we're all collectively in this together. And so it's...
a little closer.
What's that?
You want a little closer?
Oh, sorry. And so just to kind of give a little bit of feedback, what we've heard across all of our hospital staffs that we're engaged in, process is broken, lack of timely resources makes it hard for everybody to do their job, and it frankly takes too long. And so if you consider all of that feedback, essentially it translates to things are broken. And so we have essentially embarked to really solve this problem, and Dr. Siddiqui has experienced these problems firsthand, and so I'll let him shed some light on the current frustrations.
So as a physician for over a decade now, one of the biggest pain points that every physician will tell you is clinical pages. We hate them. No matter what, no matter how nice the doctor answers the phone, he is pissed off at the end of the day that you paged him. And so there's a lot of issues. There's a hesitancy in reaching out to doctors. It takes about sometimes anywhere from 40 to 45 minutes to get a hold of a doctor from a nursing standpoint. There's a lot of cost implications, legal implications, as well as outcome implications for delayed patient care. And about 1.75 million, as you guys can see, time wasted and delays in patient care. So, and now we were going to basically take that model and blow it up, because usually physicians are covering 1 or 2 hospitals. Our physicians are virtually covering 4 to 5 different hospitals at the same time. And so imagine the amount of pages and clinical pages they're going to be getting. So we couldn't have that model. So that's why we went ahead and created our own platform that's consolidated. So when you go to these hospitals, we kind of make them use the technology to contact our physicians. So it could be hospital A, B, or C. Everything will be coming into our platform for communications, and the physicians know what to answer, when to answer as well.
And I just want to reinforce that one statistic: 30 to 50% of clinical communications are non-urgent. So that's a lot of noise to declutter when it comes to really addressing critical issue and being able to separate and parse through that pool of requests that are coming through, especially when you consider the criticality of something that could be life-threatening, right? And so that statistic is important, because that is the focus of us, is to be able to quantify what we can parse out, what we can separate, to ultimately be able to prioritize against it. And just to kind of talk about the challenges downstream.
Yeah, and majority of the lawsuits are ending with issues with miscommunication or not timely communicating critical issues at the right time. And so about 80% of serious medical errors are due to communication failures. And as we all know, the pagers are still around. They're still around, but the paging system has not, evolved at all in the longest time. It has actually gotten worse with the advent of the chat-based model, where now nurses can just message you multiple times, and that's so. Back in the day, you just you call, you get everything answered in one go. But now, you can have several different pages, several different times, and so. Unfortunately, that's where everything is going, so that's why we decided to create a secure chat platform that was a little bit more beneficial for physicians.
Fantastic. So I deliberately implanted this slide because I want to just kind of level set here. So you probably heard the term AI used, abused, overused, misused, misrepresented, and probably just dropped very awkwardly, and perhaps when there's awkward silences. The way that I've had conversation is if there's an awkward silence, just say the word AI, and that will basically return you back to normal. Everything's Gucci after that, right? But the reality is that AI has to be very prescriptive. It has to be rationalized, and it has to be purposely applied in a way that's meaningful and measurable, right? And so in our organization, we provide a framework to qualify not only AI solutions, but all across our solutions in general. And even as a business across other processes, we have to qualify it through some sort of framework. And just to kind of give you a lens into that framework in the context of AI, the first question that we ask is this solution solving for a real problem? And that is important, because to qualify a problem, you have to go down the path of understanding the causes of those problems, right? You also have to understand the significance of those problems. Is it a problem exclusive to us? Is it a problem that is persistent across the industry? And so to go down that line of questioning and that criteria helps us simply condense the problem statement into a very simplistic but very rationalized, justified, and qualified problem statement, right? So that's incredibly important. The second question that we have to answer is if this will drive efficiency. So if you look at AI solutions out in the market, one of the use cases that 90% of them solve for is efficiency. It's not exclusively efficiency, but it is efficiency. If you take the concept of automation from intelligent responses, right, saving you time to essentially measure certain inputs. All of that takes time, but with AI, it condenses that time and makes it a lot more efficient. So efficient translates into time. And so we ask the question, is it efficient? Because that translates not only to time, but at the end of the day, it also translates into dollars. It can translate that into a lot more downstream. Is it quantifiable? Anytime we talk about solutions within our organization, we have to understand and put the index of measurement in front of us. Let's build a robot. Okay. Why are we building a robot? Well, it's cool. It attracts attention. Yeah, but quantify it for us, right? Quantify it for us so we can rationalize it and make it valuable not only for us, but ultimately make it valuable for our clients, as well as obviously make it valuable for our patients. And the most important thing is we are a healthcare organization. Will it elevate patient care? And that's the most critical aspect of what we do. And I think we can all collectively say yes to this in all of our efforts, but it is probably one of the most fundamental things that we're paying attention to help qualify our solutions, specifically in the lens of AI. We mentioned this because this should serve as a framework, and feel free to talk to us about our experience of establishing the framework to help qualify our solution. So LiveMed Health enters the chat, very literally enters the chat, right? We have essentially built an AI-powered clinical communication, and I'll let Dr. Siddiqui talk about the benefits of that development effort.
Yeah, so basically the thought process was that once you're getting several different clinical pages from several different hospitals, we wanted to make sure that the 10 to 15% of critical messages are not missed across all hospitals. So what our AI does, currently the control is at the nurse's station, basically, where they'll say it's high priority or low priority. They'll always, for the most part, pick high priority because they just want to get a hold of a doctor as soon as possible. But what our AI does is that it's been trained by our AI model over 8 different specialties. It's trained by our physicians over 8 different specialties. What it does is it actually reads the text from the nurse, prioritizes it based on medical acuity. All it does is basically says red for high, moderate for yellow, and then green for low. And in that case, what happens is right now, all the texts and pages are being answered on a time basis. So whichever came first is the one you kind of answer right now. In this format, what happens is there's a list of messages. Those messages will be displayed. Some will be displayed red, some will be yellow, some will be green. The physicians will get on top of the red one first, and then so on after that. So the idea is basically it's our AI model, trained by our physicians, and so far our physicians have been loving it. So it's been a good thing.
And just to kind of condense it down to exactly what happens in order of operations from a technology perspective. So a nurse enters a request into the chat. That chat that gets parsed out between the different phrases that comprise that particular entry. That word combination gets scrubbed across millions of different phrases and word combinations. It then gets scrubbed against our center of truth to be able to qualify and validate that statement. And then thirdly, it takes contextual cues around where the origin of this message is coming from, understands the context of that message, understands the location and the user profile type, and then ultimately routes, if it needs to the right recipient, which is a specialist on the other end, considering the fact that that physician might be backlogged with other patients. So it has to reconsider that entry path. All of that happens within less of a fifth of a second, right? So I want us to really be able to pay attention to that, right? Because a fifth of a second is relatively insignificant to the magnitude of the challenges that Dr. Siddiqui talked about, right? And if we're looking at delays from paging from a nurse to a doctor, a delay that can take up to 8 to 10 hours, and we can reduce that time frame by as much as 90% for the most critical cases, that's incredibly significant. If we can walk into a hospital and tell them that we've invested a solution that cost us a fifth of a second, but it will save you up to 90% of that time frame to request the right specialist, that's completely valuable. That's a very compelling value exchange. And that's why we've gained the traction that we are, and that's why we put these solutions in place to be able to essentially address the criticality of the most critical healthcare requests. And so we're not stopping there, right? We talked about that workflow, step 1, step 2, step 3. That third step we're also now focusing on, and we're not the only ones, right? We've got friendly neighbors within the pavilion that are all working together on this. But in our efforts to really streamline the workflow for our physicians and for them to be able to push notes in the most efficient way so that they can pay attention to more patients, we've essentially started down the path of infusing AI-informed tools to be able to comprise tighter EMR integration. And we've just partnered with Sully.ai, who's at the front of the hall, to be able to help us in this effort. And they will be essentially collaborating with us to help support our use cases and be able to help our doctors tightly integrate with a number of EMR interfaces concurrently across multiple EMRs at a time. This is a huge challenge. I won't get into the details. We only have a few minutes right now, so I want to be honest with our time. But essentially, we wanted to end there to really kind of talk about how we're elevating acuity-based prioritization to help us in our efforts and increase the quality of patient care in a very, very timely way. Dr. Siddiqui, any last words?
I think that was great. I think one of the other big pain points of virtual care, and I do feel like as outpatient telemedicine market has skyrocketed. Every company is doing outpatient telemedicine. Inpatient market, meaning hospital care telemedicine, is just about getting started. And when the biggest elephant in the room is the physician shortages that's looming over us, especially in the next 10 years, it's going to be I think about close to 150,000 of physicians that we're going to be short. The idea is to increase the access of one physician to 4 or 5 different hospitals rather than have one physician cover one hospital. Now, the problem is these hospitals don't run on single EMRs. Even if they have Epic, they'll have different instances of Epic. And so that's when we decided to make our universal EMR platform where our physicians are covering 4 or 5 different hospitals, and this platform will connect to several different EMRs concurrently, real-time, dynamically, read and write capabilities, because that's exactly what we need to make sure we have efficient care, basically.
Fantastic. For any follow-up discussions, conversations, we're right over there, so we're just going to step down the stairs. We'll be at our booth, so happy to entertain questions. Glad you guys attended. Thank you for attending. For the viewers at home, thank you as well.